Hi, class. Let's take a look at the brainstem. Okay, when we talk about the brainstem, we are referring to three parts of the brain. We're talking about the medulla oblongata, which is the most inferior part. As we move a little bit up, we get into the pons. And as we move higher up, we're getting into the midbrain. Now, within the brainstem, this is where we have a region called the reticular formation. And the reticular formation has a lot to do with keeping you awake, keeping you conscious, keeping your postural muscles active, helping you wake up when your alarm clock goes off. If you're in a deep sleep and there's fire in the house and you can smell smoke, that wakes you up. Okay. That's the reticular activating system. And it's found scattered throughout the brain stem, the medulla, the pons, and the midbrain. Let's look at the first part of the brain stem, which is the lowest part right here, called the medulla oblongata. Okay, the medulla oblongata is a continuation of the spinal cord, but it's also a continuation of the brain, right? The brain, everything up here in the skull, but then at the lower end of the skull, you have that magnum foramen. The magnum foramen is the hole at the base of the occiput. And the medulla oblongata extends through the magnum foramen and is protected by the top two vertebrae, C1 and C2 vertebrae. Now, most textbooks don't explain it that way. They'll say that what's inferior to the magnum foramen is the spinal cord, and that the brain is above the magnum foramen, including the medulla. But in functional MRI, the medulla descends down to the C1 and C2 vertebrae. However, when people die and we do human dissection, people dehydrate when they die, and you lose a lot of water density and water tissue. So what happens is the medulla oblongata pulls upward. It pulls superior through the magnum foramen, so that when we do dissections, it appears that the medulla is above the magnum foramen inside the skull. But when we're living, from a functional perspective, that part of the brainstem, the medulla oblongata, descends below the magnum foramen and is protected by the top two vertebrae, C1 and C2. Within the medulla, there are ascending tracts, which we know are sensory tracts, and there are descending tracts, which we know are called motor tracts. Within the medulla are the nuclei of 5 cranial nerves. Those 5 cranial nerves are cranial nerves 8. Let me see if I can do that here. 8 through 12. There are 12 cranial nerves. So cranial nerves 8 through 12, those nuclei originate in the medulla. Remember what nuclei are. Nuclei is a group of nerve cell bodies that are located in the CNS. That's a nucleus. Remember, a ganglia is a group of nerve cell bodies outside of the CNS, like the dorsal root ganglia. So nuclei is a cluster of nerve cell bodies located within the central neural system. So cranial nerves 8, 9, 10, 11, and 12 originate in the medulla. Another important feature of the medulla is this is where the cardiovascular center and the respiratory control center lie, in the medulla. The force and the rate of the heartbeat and the diameter of blood vessels. So you're talking about your rate, your rhythm, and blood pressure are controlled by the medulla. I've been really blessed to be able to help people with high blood pressure and arrhythmias, not through using medications or anything unnatural, but we use that upper cervical spine to reset or to remove neurological interference at the level of the C1, C2 vertebrae. We could do pre-blood pressure and then post-blood pressure checks. So before we do a treatment or an adjustment of the upper cervical region, take the patient's blood pressure, make the adjustment, let them rest for a period of time, and then recheck their blood pressure and watch it drop. Years ago, I'm going to say maybe 10 years ago, there was a pretty prominent chiropractic physician. I think he was a second generation doctor, Dr. Dickholz, and he did a study with a cardiologist. I think it was from Boston University, if I remember correctly. And what they did was the first study of its kind to treat patients with high blood pressure without medication using the upper cervical spine treatment. And what they had found in this study was that it was one adjustment, nothing more than that, one upper cervical adjustment to the atlas. I think it lasted 6 to 8 weeks, and their blood pressure dropped 10 to 20 points, which is more than the top medications on the market today. So the conclusion was that if the blood pressure is high and the cause of that high blood pressure was neurologically induced, then of course it needs a neurological solution. Now, if the blood pressure is high from inflammatory reasons or sodium and potassium reasons, then obviously this type of procedure isn't going to have much of an impact. It's if the cause is structural due to the distortion of the atlantoaxial region, the C1, C2 vertebrae, creating interference to the cardiovascular control center. Besides the study from my own clinical experience, I have many records, one after the other, being able to help patients with blood pressure dysfunction normalize. Besides the heart center, the respiratory centers here, and I think we may have spoken about this in a previous video where I had mentioned SIDS, sudden infant death syndrome. Sudden infant death syndrome, with Dr. Gottfried Gutmann, he autopsied 1,500 babies and found that in 100% of the cases, these children that died of SIDS with these autopsies, he discovered they had atlantoaxial instability. So if there's instability or neurological compromise at the C1, C2 area, the heart and respiration is going to be dysfunctional. So sudden infant death syndrome, these babies just stopped breathing. Now, if the cause was from traumatic birth and there was some sort of trauma at birth that created some degree of structural weakness at the C1 and C2 region, then yes, we can understand why that child sadly could have died from sudden infant death syndrome. From the medulla, there's information that can go in and out of the cerebellum from there. And there are some reflexes in the medulla that are the reflex centers for coughing, sneezing, swallowing, and even vomiting are part of the medulla. When we look at this type of view of the front surface of the medulla, one of the things that I want you to take a look at is this region here called the pyramids. The pyramids are made of motor tracts, primarily the corticospinal tracts. And what I want you to see, if we follow these pyramids here, and we follow this down, we can see that it crosses over this way. And if we follow this motor track down, we can see that it crosses over this way. And where they crisscross, if I go like this, right, now we look like we're talking about Roman numeral 10, which is Deca, and it's called the decussation of the pyramids. It's where they crisscross. These, again, are the cortical spinal tracts. Where they decussate or cross is the explanation of why the left side of the brain controls the right side of the body and why the right side of the brain controls the left side of the body. The left cortex or cerebral cortex controls the muscles on the right side of the body. Okay, this area here called the olive or the olivary nucleus, this is an area of the medulla that is going to send input into the cerebellum. So messages that go into the cerebellum are involved in helping us coordinate precision to our movements. When we look at the dorsal surface or the backside of the medulla oblongata, there are a few important things that we can see from back here. One of them is going to be the fasciculus cuneatus and the fasciculus gracilis. These should sound familiar to you because when we did the posterior columns, right, when we did the spinal cord like this, when we drew this out like that, this section back here were the posterior columns, which dealt with proprioceptive awareness. So the fasciculus cuneatus and gracilis are part of the posterior columns that deal with proprioceptive awareness, vibration, two-point discrimination. It's just that the fasciculus gracilis dealt with those functions of the lower half of the body, and the fasciculus cuneatus dealt with those things, the upper half of the body, the upper extremities. The 5 cranial nerves that originate are cranial nerves 8 through 12, but you need to be familiar with them in Roman numeral. You typically won't see them written this way on an exam. You'll have to be familiar with them by Roman numeral. So if we look at cranial nerve 12, cranial nerve 12 is the hypoglossal. Glossal means tongue. It's going to control the muscles of the tongue during speech and swallowing. When we have someone stick out their tongue, this tongue should be able to go right down the center. If it deviates to one side or the other, then there is injury to the medulla, because that's where the hypoglossal nerve originates. Injury is going to deviate the tongue to the weak side, to the injured side when protruded. Okay. You could also test this simply by asking a patient, push your tongue to your right cheek on the inside. They hold it, and then you push, and it should lock. And then you have them push their tongue to the left cheek. They hold it, and you see if you could push it. If there's weakness, you could tell that way, as well as sticking the tongue straight out. Cranial nerve 11 is the spinoaccessory nerve, and that controls the skeletal muscles of the throat. And it also controls 2 muscles of the cervical spine, the SCM and the trapezius. The sternocleidomastoid and the trapezius muscle are innervated by the spinal accessory nerve, cranial nerve 11. Now, the vagal nerve, cranial nerve number 10, the vagus nerve, vagal nerve, this makes up somewhere between 80 and 90% of the parasympathetics. Remember, the parasympathetics is called the craniosacral outflow. And that's because the cranial division is cranial nerves 3, cranial nerves number 3, cranial nerve 7, cranial nerve 9, and cranial nerve 10. So cranial nerves 3, 7, 9, and 10 are the cranial division. And then the sacral division of parasympathetics is sacral segment S2, 3, and 4. So it's the craniosacral segments, parasympathetic, craniosacral. The vagal nerve makes up 80 to 90% of the parasympathetic. It controls the heart, the smooth muscle of pretty much all of the internal viscera of the abdominal organs. It controls the lungs, the stomach, the kidneys, the liver, the spleen, the intestines, the ovaries, the testes. All of that is controlled by vagal nerve. You can see here the vagal nerve innervating all of these structures. And again, another reason why, as a doctor of chiropractic, we can influence the function of any of these organs that you see here. There have been babies that I have adjusted in the past over the course of 28 years from birth trauma, babies that can't hold down food and they just projectile vomit. And that's because the sphincters here, the smooth muscle sphincters between the esophagus and the stomach, are controlled by the vagal nerve. And if there's damage up at the atlas between C1 and C2 and the vagal nerve is being interfered with, the opening and closing of this valve to allow food or milk or anything into the stomach, it gets obstructed. So anything that goes in can hit this closed sphincter, this closed valve or smooth muscle, and it just comes straight up as projectile vomiting, forceful projectile vomiting. So you can see the vagal nerve controls the lungs, it controls the heart, controls the stomach, the spleen, detoxification, the liver, the kidneys, the pancreas, as well as the colon and the intestines. It's probably the most important nerve within the body. And you've heard of the brain-gut connection, right? The brain-gut connection. This is one of the reasons why your mood, the mood that you're in, can make you hungry, or you could lose your appetite, right? You get into an argument, I'm not hungry for anything, right? Your mood affects your appetite for food, but also what you put in your stomach, that's in your stomach and intestines, the microbiome, the bacteria, give off the byproduct of chemicals that ride up the vagal nerve into the brainstem and can impact brain function. So the vagal nerve is a two-way street of sensory and motor function from the brain down and from the intestines up and from the stomach up. Okay, the ninth cranial nerve, the glossopharyngeal, cranial nerve 9, is involved in lifting the throat during swallowing. It's involved in controlling one of your salivary glands that's called the parotid gland. And it deals with taste to the posterior 1/3 of the tongue. And the type of taste that it controls is the taste of bitter. Bitter to the back of the tongue, to the posterior 1/3. That's cranial nerve number 9, called the glossopharyngeal. When you say to someone, say, ah, and you shine a light in their throat, you should be able to see the uvula that moves up right up the center. But if there's damage to the glossopharyngeal nerve, if someone had a stroke and the blood supply to the medulla was being affected, then you'll see that the uvula deviates to one side or the other. The musculature on both sides of the throat, to the left and to the right of the uvula, need to contract simultaneously and lift up to pull the uvula right up the center. The glossopharyngeal nerve is also involved with the gag reflex. If a doctor comes in with a tongue depressor and hits the uvula, you should gag. That's because cranial nerve 9 controls the sensation or the sensory part to the back of the throat there. Cranial nerve 9 is sensory, whereas cranial nerve 10 controls the muscles. So cranial nerve 9, parotid gland, and the sense of bitter, tasting bitter, to the back of the tongue. Now, I haven't done it yet, but when I get into cranial nerve 7, I'll mention it here. Cranial nerve 7 does sweet, sour, and salty to the rest of the tongue, which is the anterior 2/3. So the anterior 2/3 of the tongue is controlled by cranial nerve 7, and it does the other sense like sweet, sour, and salty. Whereas bitter is cranial nerve 9 to the back, sweet, sour, and salty is cranial nerve 7, but the anterior 2/3 of the tongue. Cranial nerve 8 is called the vestibulo-cochlear nerve. So it's 2 branches to this nerve. And that's because when you look at the ear, there's a vestibular portion. Vestibular portion deals with your sense of balance. And then there's a cochlear portion that deals with hearing. So the vestibular part has receptors that are going to help you deal with your balance, and the cochlear part is going to have receptors in the cochlear of the ear for hearing. When there is dysfunction to the cochlear nerve, that can result in deafness, or the abnormal sound, what people call ringing in the ears, is called tinnitus or tinnitus. When there's damage in the vestibular branch, that can result in vertigo, which is the feeling that the person is spinning. Or they have ataxia, and ataxia is very poor coordination, especially when they're walking. They're very, very much off balance. So when we look at the ear in this picture right here, let me just change the color to black for a second. Right here, that's the vestibular portion, which they call the semicircular canals. This portion here that looks like a shell or a snail shell, that's the cochlear. So the yellow is the vestibulo-cochlear nerve, which is 2 branches. This is the vestibular part going to the vestibule, and this is the cochlear part going to the cochlear, right? Sound waves come in this way, and they hit your eardrum, the tympanic membrane. The sound waves are going to vibrate the drum, the eardrum. The vibration is going to go through these 3 smallest bones in the body, the malleus, the incus, and the stapes, those 3 smallest bones. And it's going, as this vibrates, it's going to send a vibratory percussive impulse into this cochlea. And there's fluid in there that's going to vibrate and shake, and the vibration is going to move the sensory organ in here. It's going to vibrate those little sensory hairs, and it's going to send a signal of that vibration into the cochlear branch that will eventually go to the temporal lobe of the brain, and you'll be able to hear. This part that has the semicircular canals, this is the anterior canal. Back here is the posterior canal, and on the side is the lateral canal. And then these canals are fluid. It's called endolymph. And this fluid is moving. It acts as a carpenter balance. You know, when you want to see if a picture frame is level, or if you're mounting a TV mount nice and level, you put that carpenter tool that has the little liquid with the bubble in the middle, and you can change the angle of that, and the bubble starts to move until you find the level, and then the bubble will be right in the center. Well, in each of these is fluid and a bubble. And when you move your head in different positions, The bubble moves, again, stimulating these little hairs inside these canals. And as these little hairs move, it sends signals into the vestibular nerve that helps you maintain your balance and equilibrium. When there's balance issues, let's say there's a crystal that gets dislodged in one of these canals and it's constantly stimulating one of those hairs, you get the feeling that you're always spinning, right? Like if you're a little kid and you spin to the left and you spin, you keep spinning 10 to 20 times, and then you stop spinning left. Once you stop, you still spin left. It feels like you're still moving, okay? When you have a crystal that gets dislodged and it gets stuck in here, it's constantly triggering those hair cells, and it gives you the feeling that you're moving when you're really not. And a lot of people end up using motion sickness medication to try and treat them. But when it's a condition that's called benign paroxysmal positional vertigo, benign paroxysmal positional vertigo, meaning it's predictable, meaning some vertigos happen and no one knows when it's happening, but BPPV, benign paroxysmal positional vertigo, is very predictable, and it happens with a particular movement of the head. Some people turn their head left and it sets them for a trigger. Some people look up, sets them for a vertigo. Some people are in bed and when they rotate right, everything spins. Those are fixable. It's very fixable using a maneuver called the Epley's maneuver. But you have to be very specific in determining which canal you're treating. Otherwise, you can really make this worse. If it's a vertigo that's caused from a chemical stress, like a certain medication, those are difficult. Like blood pressure medications can cause vertigo. And if there's damage to the cochlear portion, let's say someone takes too much aspirin or baby aspirin, that type of overdose is known to damage the cochlear nerve, creating tinnitus, that ringing in the ear. There are certain viruses that can attack the vestibulocochlear nerve, and that can create balance issues and tinnitus and a degree of deafness. Okay, let's move one level up to the pons. The pons, which is this region right here, pons means bridge, and the pons has the pneumotaxic and apnoistic area. Now, these two areas are involved in controlling the depth of your breathing, the depth of your inspiration, and then it tells you when to stop, and then the rate and depth of your expiration, and it tells you when to stop. So it controls the depth of your inhalation and exhalation. The other thing about the pons is that it's where the nuclei of cranial nerves 5 through 7 originate. Okay, so let's look at cranial nerves 5 through 7. 7 is called the facial nerve, and the facial nerve is going to control your facial expression. The facial nerve is going to control the salivary gland. Remember, cranial nerve 9 control the parotid gland, but the facial nerve controls the other salivary glands, like the sublingual and submandibular glands. Cranial nerve 7 is sweet, sour, and salty. Sweet, sour, salty 7. Cranial nerve 7 is also responsible for shutting the eye. So what I like to do is I like to make a number 7 with a hook. This is the number 7, and its job is to grab the eyelid and close it, like blinking. Okay, so cranial nerve 7 helps you blink to close the eye. Like if you're walking outside on a summer day and a little insect goes in your eye, you blink. It forces it out. Since I'm mentioning that, we'll talk about what cranial nerve keeps the eye open. There's a cranial nerve that's responsible for keeping the eye open, and that would be cranial nerve 3. So I like to make 3 columns, like the Greek columns. So 3 columns keeps the eye open. Cranial nerve 3 keeps the eye open, but cranial nerve 7 is designed to shut the eye. So when people have a clinical condition, a virus that attacks the facial nerve, we call that Bell's palsy. Bell's palsy, that's where you lose the ability to control the facial muscles on half the side of your face. So you can smile, but half your face doesn't. You can blink, but the side that's involved, that eye won't blink because of the paralysis. So cranial nerve 7 is all the facial expressions, raising your eyebrows, smiling, frowning, whistling, puckering up for a kiss, sweet, sour, salty to the anterior 2/3 of the tongue and the salivary glands. And it also is responsible for shutting the eye. The abducens nerve, when you look at the word abducens, we see the word abduct. Abduct. So if this was the eye, here's the nose, and let's say here's the other eye. And let's say we're not looking at that eye, we're focusing on this eye, on this side. When we move the eye this way, that's controlled by the lateral rectus. If we move this eye and test it this way, that's the medial rectus. If you move the eye up and out that way, that's the superior rectus. And if we test the eye down and out, that's the inferior rectus. When the eye goes up and in, that's the inferior oblique muscle. And when you move the eye down and in, that's the superior oblique muscle. So the lateral rectus moves the eye laterally, which is away from the nose. It's abducting it. You're moving it away from midline. So that's why the Lindner's chemical equation is SO4 LR6 all over 3, which means the lateral rectus is controlled by the 6th cranial nerve, which is the abducens. The superior oblique muscle is controlled by cranial nerve 4. So we'll put a little 4 here. We'll put a little 6 here. But all over 3 means all the other eye muscles, except for these 2, are controlled by cranial nerve 3. Okay. Okay, and the last cranial nerve for the Pons is called the trigeminal. Tri means 3, and it's because there are 3 divisions to the trigeminal nerve. When we look at those 3 divisions right here, we see that one division right here, V1, goes to the eye. It's the ophthalmic branch. Here is V2 going to the maxilla. And down here at the bottom is V3. V, the reason why I say V is because that's Roman numeral 5 for cranial nerve 5. It's trigeminal because there's 3 branches, V1, V2, V3, ophthalmic, maxillary, and mandibular branch. This is what the dentist will hit with Novocaine so that they can work on your upper jaw or lower jaw on the teeth without you having the sensation of it. There is a virus that attacks this cranial nerve at times. And when this cranial nerve is attacked by a virus, it can cause what's called trigeminal neuralgia. Anytime you hear the word algia at the end of a word, it means pain. Like fibromyalgia is muscle pain. Arthralgia is joint pain. Neuralgia is nerve pain. So trigeminal neuralgia is when the person has lightning pain to their face. And it is the most painful neurological condition that exists. It's considered to be suicidal pain because it's like knife-like lancinating pain to this distribution of the nerve. The trigeminal nerve just doesn't control the sensation to the face, but it also controls the muscles of mastication, those chewing muscles that you learned. We call them time muscles. T-I-M-E, time. And that's for temporalis, masseter, and the I and the E. The I is for internal, the E is for external. There's an internal and external pterygoid. So the temporalis, the internal pterygoid, the masseter and external pterygoid are your time muscles. Those muscles of mastication for chewing are controlled by the trigeminal nerve. Cranial nerve 5 is also dealing with touch, pain, and temperature receptors to the face. It's the only cranial nerve that actually has a dermatome. It's the only cranial nerve that has a dermatome. It deals with sensation to the face. And remember, dermatomes can be impacted by a virus called shingles, which is also a form of herpes, herpes zoster. So herpes zoster can affect any dermatome, including the pathway of this nerve distribution to the face. And we'll finish up the brainstem with the most highest up portion that's called the midbrain. The midbrain is above the medulla and the pons. If we look at it here, it's this section right here. So down here is the medulla, here is the pons, and then right here is the midbrain. All three of those combined are considered to be the brain stem. So in the midbrain, there are some cranial nerves number 3 and cranial nerves number 4. And there's an important region in the midbrain that's called the corpora quadrigemina, which literally translates to the body of 4. Corpora, like a corpse. Corpora quadrigemina means body of 4. I'll show you what that is. And then I also want you to remember red, black, and the twins in the back. When you think of the midbrain, I want you to think of red, black, and the twins in the back. The twins are these 4 structures. I'm just making 4 circles right here. These 4 circles are the corpora quadrigemina. They're the twins in the back. If I go back a page right here to the midbrain, I'm going to circle it or put a square around it right here. 1, 2, 3, 4. Those 4 structures are the corpora quadrigemina. It's made up of 2 superior colliculi and 2 inferior colliculi. Those 4 structures are the twins in the back. So when I say red, black, twins in the back, the twins in the back are the corpora quadrigemina. The red is for the red nucleus. And the black is substantia nigra, which means black substance. Okay. The functions of the midbrain is that it conveys motor impulses from the cerebrum to the cerebellum and the spinal cord. So it's definitely one of those relays. It's also involved in auditory, hearing, and visual reflexes. So as you read the screen and your eyes have to track from left to right, that involves eye movements. That's a visual reflex. If there's a loud bang or a loud sound and your head moves and your eyes move in the direction of that sound for protective measures, again, That's auditory reflexes. Those involve the corpora quadrigemina. So when we look here, here's the red nucleus. What gives it this red appearance is that it's very rich in blood supply and contains lots of iron. But the problem with iron is that it can oxidize, it can rust, especially in unhealthy individuals. The substantia nigra, which is the black substance, which is here, black substance, that helps to control subconscious muscle activity because it's responsible for releasing dopamine. When people have a dopamine deficiency, like in Parkinson's disease, they have very tight, rigid muscles. It's the substantia nigra that's responsible for releasing dopamine. But if there's a dopamine deficiency issue or damage in the substantia nigra, there's going to be a lot of issues with muscle control and muscle activity. Here, in this picture right here, this is showing the corpora quadrigemina. So numbers 1 and 2 are the superior colliculi, and then number 3 and 4 are the inferior colliculi. The superior colliculi are coordinate the eye movements with visual stimuli, such as reading, and then the inferior colliculi are going to coordinate your head movements when you hear a loud bang or a loud sound. Okay, that's the midbrain. In terms of the cranial nerves, remember that little silly Lindner's chemical equation of SO4 LR6 all over 3 tells us that the superior oblique muscle is cranial nerve 4, which is the trochlear nerve. Lateral rectus was the abducens nerve, and all the other eye muscles are the oculomotor or cranial nerve 3. And here's our third cranial nerve. So the third cranial nerve is going to be responsible for helping to keep the eyelid open. Remember, I said we'll draw an eye and we'll draw the 3 columns to keep the eyelid open because it controls the levator palpebrae muscle. When cranial nerve 3 is damaged or weak, there's a condition called ptosis, which is drooping of the eyes. You can't keep your eyelid open and it falls and droops. That's called ptosis of the eye. The eye controls the 4 extrinsic eye muscles, everything but the lateral rectus and superior oblique. And it controls 2 intrinsic eye muscles. And these intrinsic eye muscles are involved in altering the shape of the lens to help you with your vision. Cranial nerve 3 is also involved when you shine light. When it's dark, right? The pupils are nice and big, right? When you're in a dark room. But what happens is when you shine a light into the pupil, it constricts. There are muscles that constrict it. The muscles that are involved in the constriction are cranial nerve number 3, oculomotor. It's involved with constriction of the pupil. When you shine light in the eye has to see it, right? So you have to have vision. The vision is controlled by cranial nerve 2, which is the optic, but the actual constriction of it is cranial nerve 3. So cranial nerve 2 and cranial nerve 3 are involved with the pupillary light reflex. Cranial nerve 2, which is the optic nerve, is involved with the actual seeing of the light. If your eye can see the light, it picks it up. Now cranial nerve 3, which is the oculomotor, is going to make it constrict. Cranial nerve 3. Okay. And I think in one of the earlier videos, I had mentioned the reticular formation that's involved and scattered throughout the medulla the pons, and the midbrain. Okay, and that's involved in regulating muscle tone, maintaining consciousness so that you don't fall asleep during my lectures, and helping you stay awake when you're asleep. When I say stay awake, I don't mean stay awake, I meant to say awaken from sleep if you smell smoke, or if your alarm goes off, or if there's an earthquake, right? That can startle you and wake you up. Okay, we'll pause here. I think that